Hello again. We'll be starting in just a minute. If you'd like to chat in who you are, where you're zooming in from, if you'd like, particularly your interest or your experience in organizational health literacy, um, or why you're here at the conference. We're excited to have you all. All right, we'll get started. My name is Lindsay Rosenfeld. I'm here today with Kathy Leslie. We'll introduce ourselves just briefly in a moment. And we're focusing today in this very short hour that we have together, how to think about applying an organizational health literacy framework for health equity in early childhood. And the principles and the concepts that we'll be discussing today will certainly be applicable in other areas of work as well. And we're thinking about early childhood as a case study today, and are looking forward to hearing your thoughts as well. Thank you to those who are chatting in. You're welcome to keep doing that. It's a great resource to be able to know who's here and follow up after the conference. I'm seeing some familiar names as well, so let's dive in. Kathy, you want to introduce yourself and then I'll go ahead?
Sure, absolutely. Happy to be here with everyone and really looking forward to this conversation. My name's Kathy Leslie. I am a researcher and faculty member, and I am a pediatric occupational therapist, and my clinical background was in early intervention, which we're going to talk more about today. And I am really interested in thinking about what are the processes in early childhood that we could address using a health literacy model to make early intervention and early childhood services more accessible.
Thank you. So, as I said, I'm Lindsay Rosenfeld. I am a scientist and practitioner in public health. My work focuses on health equity and the social and structural determinants of health and health literacy, and particularly families with medical and developmental complexity. I do all different kinds of things in those areas. I do research at a number of institutions. I do a lot of practice work. So that I spend a lot of time facilitating discussions and doing trainings and helping people think about the assessment and implementation of assessment results related to organizational health literacy and the structures and processes and policies of their organization. And I also do a bunch of teaching in health literacy every fall, which I'm deep in right now. So this is really a treat to sort of come out and talk with all of you about these concepts. Also relevant to my work and particularly relevant to our case study for today. I'm the parent of two kids with complex medical and developmental journeys. So that certainly informs my perspective. So today we have just a couple objectives, lofty even for an hour, but we're hoping that we'll touch on them all and really get you excited or more, in depth into an area that you've possibly heard about if you have before. So we really want to identify the components of organizational health literacy so you can walk away being able to say, aha, I understand what these different pieces are, and be able to challenge them as well and how they're applicable to your work. We also want you to walk away being able to explain the relationship between organizational health literacy, health equity, and early childhood research and practice, and in such a way that you would then be able to do that for other areas of interest. Perhaps diabetes is your areas of interest, or another chronic disease, or rare disease, or what have you. And then we want you to begin with us exploring how we would implement some of the organizational health literacy best practice that's out there to early childhood as a case study. Again, with the objective being that you could then implement this in whatever area of work you are engaged in most often. So we're going to start with this overview of health literacy and organizational health literacy. And one of the central pieces to focus on in that is Healthy People 2030. And as you may or may not know, Healthy People 2030 is essentially like the federal government's strategic plan in public health. And they produce one every 10 years. So the 2030 document came out in 2020, and it's really telling us where do we want to be, in the next 10 years, and all kinds of health outcomes, oral health, child health, diabetes, you name it. And what's really interesting for the purposes of our conversation today is that health literacy is a central focus of Healthy People 2030. And in fact, one of the initiative's goals talks about eliminating health disparities, achieving health equity, and attaining health literacy to improve the health and well-being of all. So health literacy is seen as a central tenet, as a central model, as the central part of the way we can do this work. And we're really excited about that renewed focus, so to speak. And what's different this year in Healthy People 2030 than previous years is that in previous years, health literacy was mentioned, but now we really have this distinct definition of personal health literacy and organizational health literacy. Personal health literacy being the degree to which individuals have the ability to find, understand, and use information and services. So that's about individual skills. That might be patients, participants, families, staff. And we're thinking about the organizational health literacy, right? The degree to which organizations are equitably enabling individuals to find, understand, and use information and services. And while there was certainly discussion before about the system demand, organizational health literacy, and individual skills, personal health literacy, we've never had two separate sort of codifications or putting it down in writing in this way about those different ends of the demand, and that organizations have this responsibility to enable individuals to find, understand, and use information. And when we begin to look at things from that lens, as far as I'm concerned and Kathy is concerned in our work and our discussions, there are all kinds of opportunities for us working in organizations, whether that's public health or health related organizations, housing organizations, education systems, transportation, immigration, paid family medical leave, you name it, all related to health and health literacy. But we begin to just multiply and multiply and multiply the opportunities to reduce the demand and thereby increase or make it more possible for individuals to find and understand and use the information and services that most of us are hoping will be used. So why is this so important? Why haven't we, said, oh, we've done it? It's for a number of reasons, particularly because we know, and this is a recent compilation report that was put together by the Millikan Institute that looked at health literacy in the United States. And there is a continued mismatch between the skills of the public and system demands. That hasn't gone away, such that 88% of adults living in the United States, 9 in 10 people, don't have the health literacy skills that they need to navigate the health system and other systems and promote their well-being. And so, yes, education is important. Educational equity is important, and we should all be working with our educational partners. But if we're not squarely in the school system, then there is not a lot that we can do about individual skills on a population basis. And so we really need to be thinking about where we can optimize what we have control of, which is the demand that we're placing on participants, families, community. And so we want to continue to talk about that role of it, right? And in particular for our case study today, to talk about why those implications are so clear for child health. So we know that parent literacy impacts child health. And we know that the system, the demands are a big part of that problem in so far as parent literacy impacts child health. And the questions are, right, what is it that we can do as organizations, as structures, to examine all of the systems aspects that can align healthcare and other organizational demands with the health literacy skills of families, right? So we know that all these parents don't have the skills that match the demand needed to navigate systems that their children need to use. So again, we come back to this idea of universal precautions, which hopefully you've heard about, this being the second day of the conference, or you've heard about in some other way, which is saying that we need to use clear communication and apply organizational health literacy principles all the time. We don't need to spend time thinking about what are the skills of the people in front of us. We know 9 of 10 adults in the US struggle to navigate the systems. So we are going to apply these principles and do universal precautions, make the materials easier to read, make the websites easier to navigate, make our environments easier to move through, make our forms easier, make the processes more transparent, um, all the time, right? Because we know it is our families and our patients and our community who are struggling with these skills. And we have the opportunity in our structures and in our organizations to not think about, just like with hand washing, right? Doctor, nurse, whomever washes hands, an early intervention practitioner before they go into the house, they wash hands no matter what. They don't think about whether they were just touching their face or just went to the bathroom and did they wash their hands or not. And they don't think about what they're walking into. They just do it every time. And that's the approach that we take and that the literature has suggested with organizational health literacy. And within that, we really need to think about these other structural sort of overlays, perspectives that we can continually bring into this work to make sure we're considering cultural humility, to make sure we're considering racial equity, to make sure we're considering across the life course what this looks like, right, for families, for children. Thinking about family engagement and how do we incorporate that as part of an organizational health literacy strategy. How do we think about the different levels, where the child and the family are, what the community services are like, what the policies are like, and using all of this to implement our organizational health literacy frame. We know that organizational health literacy and that perspective, assessment, and then implementation and change can improve equity in early childhood. And we know that getting people what they need, not getting people the same thing, really boosts those, both that there's an equitable process as well as that there are equitable outcomes. And today we're really focusing in on health literacy as one of those structural and systems perspectives, but with these other contexts, certainly. It's that constant asking ourselves questions and integrating these other pieces. So I want to talk about more specifically, what is organizational health literacy? And really to think about what are the component parts. This is a graphic, a model that was proposed by Dr. Rima Rudd, who has a long history at HARC and with the Institute for Healthcare Advancement, who really talks about health literacy as an interaction. She talks about these 4 component parts: skills, here in the blue, skills of individuals, skills of families, skills of professionals. She also talks about text. What is it that we have to interact with? What do we have to hear? What do we have to respond to orally? What do we have to deal with in writing on websites or pamphlets or quizzes or calculators that talk about our risk of something? In all those component literacy skills, right? Reading, writing, oral, from the spoken, oral, from listening, numeracy, numbers, and postings as well, right? What does the signage look like in a space? How do we figure out how to take the public transportation and read that transportation table in order to get where we're going, or follow driving directions, or figure out where parking is, and then make our way to the institution, make our way inside, find what we're looking for in that place? How do we do that all online? Navigating telehealth, websites. And what are the tasks? What are those activities that we have to do with all of this information and the information interacting with individual, professional, patient, family skills? And then finally, the 4th piece in green, the context. What are all the systems factors that facilitate, that make it easier to do all these things, or that create barriers and make it harder to do all those things? And within that, certainly, is the emotive context, right? If you are seeking an appointment, or you are looking into a service, or you are offering a service that can be very emotionally charged, right? The entire milieu, the entire sort of atmosphere and feeling of moving through these processes and tasks, making an appointment, scheduling a special test. In our case, with the case study, having someone come to your home and evaluate your child who you're concerned about, right? How does that emotive piece impact literacy skills, make it easier or harder to navigate these processes and systems? This is not for you to all take in this moment. These slides will be available, but it's just to give sort of a hint at the different kinds of questions that we can be asking across these domains. And as Kathy and I have thought about this model that Dr. Rudd proposed, you know, we really began to think more, well, what would we be asking in each of these pieces? And it's not that you're going to be able to look at every single piece at the same time, all in the beginning, but it's to give a sense, right, that all these pieces are interacting together, and then really thinking about what are my priorities, what am I working on right now, what would I like my organization to be working on, or what is my supervisor asking that I work on, and how can I begin to incorporate some of these questions and perspectives into the work. And a very important part of that, which we will continue to talk about, is user engagement. How am I talking to the professionals who deal with scheduling, or involving them rather? How am I talking to the families or the patients, or other staff who are involved in these processes, who sort of create them, who have to use them, who come to them, right? And using that to really answer some of the big questions. So I'm going to pause there, and we'll really going to begin together in our remaining time to apply this conceptual model, so to speak, with a case study focused on early intervention. So thanks, Kathy.
Great. So happy to have all of you here and to have this conversation. So as we move into the next few minutes, we're going to sort of talk you through an organizational health literacy case study that we're then going to break up into small groups and sort of apply this model that Lindsay's been sharing to try to come up with some possible identification of solutions, identification of barriers that we see in lots of healthcare and educational systems, and how that might be impacting the case that we're going to look at. So we're going to try to apply this organizational health literacy model to an identified systems issue based on a study that was published in 2020. The goal of the study was to track more than 14,000 children with high rates of developmental delay from an urban safety net population as their families navigated access to needed developmental services. So this is the, if you want to go back one slide, Linz, this is the study that we're using as sort of the framework. We're going to look at the results that they found from doing this study and use this as a basis to have some conversation around coming up with some solutions. So it was based on this manuscript from BMC Pediatrics by Beth McManus and colleagues. And the link to the manuscript is in the chat. So if you'd like to access it, you can. Lindsay will be pasting that in. But we're going to do a brief description of the study now to kind of get us started. This study is pretty broad. So some of the details from the study are not in this little recap because we just don't have time in this 1 hour to cover everything that this group looked at. So we're going to move through and kind of give an abbreviated summary so that we can use that information in our discussion. Okay, next slide. So just to give a quick background on the setting for this study. So early intervention is the service system that was studied in this paper, which is Part C of the Individuals with Disabilities Education Act. This is a federally mandated program that's run in every state to provide developmental services to eligible children with developmental delays and disabilities under the age of 3 years. So we know from the EI literature that families report challenges when accessing EI services, resulting in lower rates of EI service use than we would like. So many unsuccessful referrals are tied to organizational health literacy related issues, just like in other service centers, such as process mistakes or communication problems between pediatricians, early intervention programs, and the families that are trying to access services. So although our discussion today is using this EI system as an example, as Lindsay was saying, I think you will find that there's a lot of commonality between this study and other systems that all of us are working in. All right, next slide. So this is a simplified schematic, but I wanted to kind of share the process that most families go through as they try to work their way through needing EI services, getting enrolled, and then transitioning out again. So for step one, the child's developmental delay or diagnosis is identified, sometimes by a family member, sometimes by a healthcare provider or a teacher. And then next we have referral to early intervention. And in this study, the referrals were made by a pediatrician or other healthcare provider that's part of the child's medical home. So that's where the data for this study came from. And then step three is after that referral, the next step is conducting an initial eligibility evaluation by the EI program. Step four, if the child is found eligible, the next step is to create a care plan for the child and the family. And in early intervention, we call that the Individualized Family Service Plan, or the IFSP. And step five is when the family actually starts receiving EI services. And then the last step is children age out of EI when they turn 3, or if they no longer need early intervention services before their 3rd birthday. All right, next slide. So to give you a quick overview, the study followed 14,710 children with a developmental disability, and they were all referred as part of being enrolled in an urban safety net population that has high rates of developmental delay, and they were based in Denver, Colorado. So they used longitudinal child data with the aim to understand where the gaps were in this process of working their way through all those steps that we were just discussing. So they used a large group of data and they did a retrospective cohort design. And what they did is they tried to link the pediatric primary care records from the pediatrician centers that the children were going to. And then they tied that to the EI data for the centers in Denver that serve that area. And they used this data to estimate where the gaps were in the process. Next slide. So this study, as I said earlier, has a lot broader results section than what we're going to need to talk about today for our case study. So this is sort of an abbreviated version of the results. On the next slide, we're going to look at a flow chart of these results, which will also be helpful. So the key takeaway here is that out of a cohort of almost 15,000 children, less than 5% of the families made it through all of those 6 steps in order to get the EI services that they needed. Additionally, racial disparities in access were identified, with children who were Black, non-Hispanic being less likely to be referred to EI than their white counterparts. Next slide. So when we look at this flow chart, this is taken from the manuscript. The steps that we're going to look at today are outlined here. So when we go into our breakout rooms and think about organizational health literacy, we're going to focus sort of step by step. But I think one of the things I just kind of want to talk through briefly is that when we look at step 1, so being referred by your pediatrician, I think we want to think about why were only 2,746 children referred out of that big number of 14,710. So what happened that whole other group of almost 12,000 families was not referred? So a delay was established, so they were screened and a delay was found. They were referred. One little group was referred, yet this whole majority of children was not referred to early intervention. So what could have happened? What are the barriers? What helped the kids that did get referred to actually make it into the referral side? And then at step 2, when we think about accessing EI services, this includes having that first initial evaluation to see if you're eligible and then receiving a care plan. So when we look at step 2, only about a third of the children who were referred received an evaluation. So what happened between this step of getting your referral? Now the EI center has been notified that you're out there and that you need to be evaluated. But then look at how many people never had that evaluation. So why does that happen? And then lastly, step 3 that we're going to think about is less of a bigger gap, but still we see this number of 722 families that got their evaluation, met with EI, wrote a care plan, and yet still did not participate in services. So 151 families made it all the way down this chain of steps and then never made it into actually receiving services. So these are the sort of the 3 chunks of this flow chart that we're going to talk about as we move forward. Next slide. All right, great. So our activity that we're going to do together, because we don't have as much time as Lindsay and I, we wish we had to work with you on this. We're going to focus on 2 sections of the model that Lindsay reviewed. So we're going to talk about the texts and the tasks. And each breakout room will have a step to focus on. Can you go to the next slide, Lindsay? So just as a way to sort of give you some prompts, these are some of the things that we talk about, the questions that Lindsay had on the slide earlier for each of those 2 sections. And this will be on the Google Doc that you're going to use in the breakout room. So you don't need to write this down or remember this, but I just wanted to kind of show these before we go into the breakout rooms. Next slide. All right, so Lindsay's going to put the link to the Google Doc in the chat. And before we join the breakout room, you can open the Google Doc using the link. As you are assigned to your breakout rooms, it will tell you what number room you're in. So you just want to take note of that when you get into your room. As you look at the Google Doc, there's a little chart, a little table, and you'll be able to see a slot for your breakout room and what to focus on, and then write your ideas in there. And so during your discussion, we're just asking that you think about the models that we talked about today, the 2 sections of the model, and add to the Google Doc some takeaways from your discussion about some facilitators and barriers and how we might use organizational health literacy to sort of address some of these inequities in those 3 steps that were in the flow chart. So we'll have about 15 minutes in our breakout rooms, and then we'll have about 15 minutes all back together to discuss and talk further. So is the Google Doc all set?
Yep, the Google Doc is in the chat.
Okay, great.
And so take a moment when you're joining that breakout room just to note the number of the breakout room, and all the directions are in the Google Doc again. And then below those directions and slide shots, which you've seen, will be a place where you can take some notes as you're talking together. So we'll look forward to coming back for the discussion, as Kathy said, and also plenty of time for questions.
All right, so
I'll go ahead and stop sharing screen for the moment and put breakout rooms.
sure. So I was thinking about 6 rooms, Lindsay. Does that sound good?
Okay, perfect.
Or maybe 5, actually. There's 25. Okay.
Yes.
Okay.
Okay, I'm going to pause the recording. Welcome back. All right, I think everybody has returned. So we are going to dive into our discussion. Oh. Let's start with the folks who discussed step one, referral by the pediatrician. What were the text and tasks that you started to talk about that are part of that referral to pediatrician step? You feel free to unmute yourself, chat in, whatever feels good. Step one.
So Lindsay, could you hear me?
I can.
Okay, we had some audio issues, so we tried to use the chat to kind of talk through it.
Great.
So some of the things that we said are some of the reasons why they might not have been completely referred was not understanding the full process of the referral. And also potential limitations of the providers who actually complete the referrals.
Mm-hmm. Great.
I'm wondering, when you think about that, if we're thinking about the skills of the providers who actually referred them, I'm just wondering if you, what might be some barriers and facilitators around that? So did you think of any maybe ideas around ways that we could help improve that step?
We did not get that far. We spent a lot of time trying to hear each other. Sorry.
Oh, I'm sorry.
No, don't be sorry. Don't be sorry.
Frustrating.
It's the fun of Zoom. Was there any other group that did step one? It got a little confusing. There was a lot of moving around when we went into breakouts. Anybody else who talked about step one and we're thinking about all of those issues, right? Where we have 14,710 an established condition or delay, and only 2,700 were referred to early intervention. Any other things, whether you were in that step or not, that you were thinking about? So Michelle, I think it was, who was speaking. Was that right? I couldn't tell who was talking.
Sorry, it was Julie.
It was Julie. Thank you.
Yep.
Sorry, it's hard with all the in Zoom land to see who's talking. So thank you, Julie. So talking about the information, right, or the understanding of the process, and then the professionals involved in that referral. What were some of the other things? Yes, Jane, please go ahead.
Yeah, so some of the things we talked about was the time, the lack of time in a pediatrician, or a lack of time between the pediatrician and the parent and child.
Mm-hmm.
The knowledge of the provider, the process breakdown. They might not know the process, or it might not be complete in the EMR or in the staff knowledge, who's responsible for the next step. And then once you get a resource, maybe there's not enough resources. So you're on a waiting list, and then things happen. You move, you don't get notifications, your phone number changes, something like that. Then you're immediately put at the back of the list, right? So, and time passes, and life gets in the way. So it's just kind of, life becomes a barrier at that point.
Mm-hmm. So you mentioned a lot of things, right? The staff knowing or not knowing what the next step in the process is, right? Thinking about challenges on the family side, right? They get the letter, they don't get the letter, they move, something else comes up, right? And so I think some of the things in Kathy and mine's work, when we're thinking about all the things that everyone just raised in step one, is then sort of, you do that survey. Why aren't all the children who are able to be referred, right, referred? Why isn't that happening? And then picking one piece of that to get started with, right? And something that stood out to me that was mentioned, all of those things would be good starting points, but something that stood out to me was the process, let's just say in the pediatrician's office, right? Do they have a clear documented process that can be given to families, but also is part of the process, right? Of, okay, we had a kid who we're going to refer. What does that mean? What's the next step? How do we have something that checks if we've made that referral, if the family gets connected? Another big problem in early childhood with the pediatrician in EI is exchanging information, because the pediatrician office can't know whether or not the family then sort of even got to EI, right? And so what are the pieces that can be added in just on the process side, right? Just picking one thing and beginning to create it both for staff and systems processes and families in a more plain step-by-step manner. Just one piece, right? Is how we start to look at when, because you get that myriad of issues and you go, right? Like, what could I possibly do? There's so many problems, right? And we start with one piece, and typically it's the piece that seems, oh, this is related to another initiative we already have, right? Or we're trying to increase communication with nursing staff or whatever. I mean, I'm making this up, right? And trying to put it together with some of those initiatives. Maybe it's an initiative around language and interpretation services. Maybe it's right. So really making it part of the current goals to put it in. It also makes it much more doable, much more palatable, right, by supervisors and structure staff who are thinking about these pieces. What about step 2, access? So that eligibility evaluation, right? So we've got 2,700 of the 14,700 who are referred, but only 722 receive an evaluation, right, of those who are determined eligible. Of course, there will be some who are determined not eligible in receiving that evaluation, and then folks who did not even receive the evaluation. So what did people who talked about step 2 lay out?
I can speak for our group. We were thinking about that loss between the 2,700 and the 700 that are get the evaluation. So we were thinking about things in a couple of broad categories when we looked at things all together. One of the things was communication barriers in terms of technology. So like we were talking before, has the family's phone number changed since they were referred? Have they moved? Has their insurance status changed? Or we talked about access to internet, consistent internet as well for any telehealth that may be occurring. But then we also talked about the issue of potential provider communication barriers. So how is the doctor presenting this service? How is the doctor explaining what the evaluation entails, and then what services the family would be eligible for following that evaluation? So maybe fully understanding their diagnosis, taking the time to have that conversation, and understanding what services this would open the door for. So maybe not understanding what all is entailed and what is available after that eval. And then we also just talked about some stigma that might be associated with a diagnosis, and how a family may need some more conversation or some more counseling on accepting that diagnosis, and then seeking services to help their child as well.
Great, thank you. Hi, Amy.
Hey.
Very robust discussion for step 2 as well. Anyone else talked about step 2 or have a thought they wanted to add? Okay, so when Kathy and I often are thinking about this access issue, right? There's that term, access. We need to make things accessible. Get in the door, get that piece of paper, right? But if you can't understand how to navigate the space, if you can't understand that paper you're handed, if you don't understand the process and the way it's presented, if it's, very complicated and feels not transparent and hidden behind doors, etc., it's really hard to use the information that you need, right, to receive that evaluation. Many things of which, Amy, you described in your discussion, right? And so that idea, right, of how do we make sure people are going to get that evaluation? What are we going to work on first? Is it the hours that evaluations are offered and folks are working full time and can't say, yes, come to my home during that time? Is it that they don't know how to deal with the daycare setting and getting that evaluation? Are they worried about what that evaluation is going to tell them? Is it clear how these services are provided, what it costs, and what it means? Right? All of those pieces, and picking one of them to increase that access. What about step 3 in the interest of time moving through?
Michelle also just added in the chat, also if the idea of developmental milestones, growth, et cetera, is not known or understood by families, they don't prioritize this program. Yes, super great point.
Absolutely.
And this goes back to, did that initial way back in before step 1, when the pediatrician is just getting to know families and establishing relationship with them, do they have the time and the bandwidth to even educate families initially? Like, when you come here every time, I'm looking at these developmental milestones and sort of starting that conversation early enough that the family gets that basic education. We're seeing this in work we're doing at Early Head Start, that families, because there's no family education around developmental milestones, then when someone brings up a problem and starts using all of this jargon, the families just aren't understanding, or they don't picture their child on a developmental trajectory. They just think they seem happy and they're doing great, so we're good. So I couldn't agree more with needing to establish sort of that first step of family knowledge.
Right. And not to mention the varying perspectives on development, right? Just because a pediatrician or a program or the Early Head Start or the daycare or what have you introduces a developmental process, right? Or developmental milestones in a certain way, that's very cultural, right? That's different by region, that's different by cultural background, that's different by nationality, that's different, right? All the policies in different countries would suggest, right, about whether early childhood services are funded or they're not, or when you start school, or what you start with when you're in school, right? This is not a sort of in stone thing, right? And the conveying of that in that early introduction from the pediatrician's office, another piece, right, that could set the trail. What about step 3, service use? So we've got 722 kids in this study who received an EI evaluation. They're eligible, right? They can have EI services, and only 571 initiated services, 151 did not. So what's going on in step 3? So there's in the chat, while folks are deciding who will unmute for step 3, in California, a child is eligible if they are, quote, at risk for a delay. So it can be challenging for parents to take the time and energy for something they can't see or isn't happening. Excellent. Yep. And that qualification in Massachusetts, for sure. For sure.
Yeah,
that's how my kids initially participated in early intervention, because they were at risk for developmental delay. 2-parent working families, not home, babies in daycare. Absolutely. Absolutely.
And this idea again goes back to, did whoever the provider at the beginning have a good enough relationship with the family to introduce this idea of prevention, right? To step in before the child is off track due to risk factors, so that we don't have to wait and see, and then deal with it when they're 7. So I think same story goes back to building trust and having good communication at the beginning. Yeah, the no evening and weekend services, Michelle, I don't know how we address health inequities if we say we're open from 9 to 4, right? I mean, who can do that? People who have paid time off or have another caregiver that can take them, and all of those issues. Yeah.
Absolutely. And someone may have paid time off, right? Pay access to paid family medical leave. Talk about another system to move through, right? To be able to access that, to understand it, to use those services and benefits, even if you're eligible, right? We could have done that as a case study, right? Which directly affects health outcomes, equitable processes to lead to equitable outcomes, right? And thinking about the way that organizational health literacy, overlays on that, right? And just given time, we want to wrap up on that point and really allow for questions or further resources, etc. We will provide all these slides. We are more than happy, I can speak for Kathy too, for you to contact us to think through these issues and think about them in your setting. And really, we want to leave you with this idea, right, that organizational health literacy is another systems framework for you to really think about, how do I bring in all these other frameworks that, at least in our work, we want to bring in: social and structural determinants of health, thinking across levels, thinking about how community influences access and understanding and use, as well as policy, right? Thinking about this across the life course, right? This isn't a static one point in time. Thinking about how that changes across the life course. Thinking about how work, influences this, as Michelle was saying. Thinking about language and culture and all these other pieces together. And we really see organizational health literacy framework as a way to be asking all these different kinds of questions, so that we can begin to think about the ways that processes and structure are systematically creating barriers for folks to access, understand, and use information. This is systematic. It is, structured in the way that so many other structural barriers are created. And the nice thing in particular that Kathy and I always talk about is the assessments and the thinking in this work are very practical. You can really start anywhere once you get the lay of the land, and the assessments provide you with many of the solutions. And so we'll leave you with that. We take any questions. We're really happy to see you today.
Thank you so much for being here. I know everyone's so busy, so it's so great to have your thoughts and conversation.